Hello, I'm Michelle, and I am going to talk to you about my performance improvement project. After some discussion with leadership, it was determined that one of our more pressing needs at my facility is the need to do a better job of assessing and reassessing pediatric vital signs. A 7-year-old was triaged with initial vital signs of heart rate 160, respiratory rate of 18, temperature 101. The patient did not receive a reassessment of vital signs until 4 hours after the initial assessment, and then only a heart rate of 160 was posted. At time of discharge, the heart rate was documented at 100, respiratory rate 18, and no temperature recheck was done. Let's discuss the first problem with this picture. The patient has a heart rate of 160 and a temperature of 101. How accurate do we think that respiratory rate of 18 is? Secondly, only a heart rate and respiratory rate were documented at discharge. Did we fix this patient's temperature? It's tough to say. The goal of this project is to improve our performance in capturing pediatric vital signs in accordance with our policy, which is children under 6, temperature, pulse, respirations, oxygen, and BP when clinically indicated. Children over 6, a full set of vital signs. Reassessment of vital signs is to occur every 2 hours for an ESI triage level of 1, 2, and 3. These guidelines are also consistent with the American College of Emergency Physicians. Vital signs are important. For some supporting evidence, let's look at when infants are seen in the emergency department for apparent life-threatening events, also known as ALTIs. An important part of the assessment is the evaluation of vital signs, specifically respiratory status, heart rate, oxygen saturation, color, and perfusion. By improving our performance, when these patients come in, we will do a better job of monitoring our potential ALTI babies. Vital sign reassessment saves lives. In a study done by Choi et al. In 2011, a transport checklist was developed to reduce the number of unexpected events in pediatric patients during transport. A component of this was the clinical status of the patient, which included an updated set of vital signs. We have been advised in the past at our own facility by our pediatric hospitalists that our reassessment vitals were lacking. Imagine if we had had a sentinel event because we had failed to reassess our patient before transport. My team is going to consist of myself, Ashley Garner, who is the new emergency department clinical nurse educator. She's very passionate about improving our rate of capture for full sets of vital signs, and she has the access to the needed educational materials. Emily Reeb is our new clinical nurse specialist. She has access to the data we will need for the pre and post assessment of intervention. And Leslie Keys is an emergency department supervisor. Leslie has been leading pediatric improvement projects in the department. She recently developed a pediatric distraction cart. She also has a history of working in the NICU, which allows her to be a valuable resource for any nurse with neonate questions. Additionally, her position as a supervisor will help facilitate change. The project is going to take place at Providence Regional Medical Center in Everett, where I work, in the emergency department, which will be the only department affected by this project. How do we get there? Data. Our rate of capture of initial and reassessment pediatric vital signs will be needed for pre and post assessment. Emily Reeb is working on data gathering. Discover what is hindering our ability. Is it lack of knowledge, time, lack of equipment? To this end, a survey will be developed to determine the driving factors. Act. With data in hand, there will be a push to increase availability of what is needed, whether it is knowledge, equipment, time, or a combination. Leadership and learning are indispensable to each other. John F. Kennedy. Thank you so much for listening.